The purpose of this evening is to get together as physicians and providers within Kootenai Care Network around some of the work that's been done by network members here in this community to help enhance the care for the patients that we serve. And we've had a group that was commissioned by our quality subcommittee of the board to work on chronic pain. This was mostly in response to a request of our primary care service line, who felt really overly burdened with all of the issues with patients that are chronically opiate addicted, and how could they help tackle that. And so what you're going to learn about tonight is about that work that they've done. On your desks, you've got a what we call a RAT card, which is patient education that can go to patients. We'll talk about that a little bit later. We have the actual clinical pathway that was created along with some supporting documents for patients with chronic pain. And then at the bottom, we have a feedback sheet for tonight that will allow you to also, you're going to get credit from the network education standpoint, but we also have CME credit available to you. So go ahead and kick off. Tonight's going to be myself just kind of kicking off, and then we have 3 other network physicians that are going to walk through the case-based studies and kind of lead the discussion about what's in the pathway. We did have a group that worked on this presentation tonight. A lot of hard work in with Shelley Jenke and Shelley Rutledge in the back. Thank you very much, ladies. As well as our chronic pain committee. And everybody felt that it would be better to do the case-based studies instead of sitting and just reading a bunch of slides all night. So hopefully you'll agree with us. Okay, so we want to start with just level setting in the national and local stages around what's happening with opioids. So as I think all of you know, opioids are actually a natural product found in the opium poppy plant. We have a variety of prescription opioids. Some of those are natural and some of those are synthetic. And then there are the illegal opioids. All of those are highly addictive. We are where we are due to a whole bunch of factors that came together. And so just to level set, prior to the 1990s, prescription opioids were primarily used for cancer-related pain and acute injury. And then a study came out, which was not well done, that demonstrated that there was little to no addictive potential if opioids were being used for real pain. And you only had an issue with becoming addicted if you were taking opioids for what was not considered to be real pain. Additionally, there was a big regulatory push that was somewhat pharma-based around having pain become the 5th vital sign. That together with direct-to-physician advertising, which was really new at that time, really prescription opioids were the first use case, is very much targeted towards primary care physicians. Ultimately, we ended up in the situation where we are today, where it became very normal and expected, and in fact, it was felt to be not a standard of care if you were not treating patients' pain adequately. Ultimately, a lot of that ended up getting reversed. Purdue Pharma, which is the producer of OxyContin, paid $600 million for false claims and advertising. As we know, that's very little in the big scheme of things for Purdue Pharma. This all happened at the same time that we lacked the systems that we have today to monitor patients. So back in the 1990s, there was no way to know if patients were shopping around, getting prescriptions from multiple providers, and there was really no way from a state or federal level to be tracking prescriptions that physicians were providing. As we fast forward, what became recognized really just in the last decade is the connection between the prescribed opioids and ultimately heroin addiction. And 80% of heroin users started with a prescription opioid. And that prescription opioid was usually given by a family or friend for free. This book called Dreamland, published, I want to say 2011, 2012, is a really great description of all of these factors that came together in the 1990s into the 2000s that led us to where we are today. You can hardly get on the news and not see this, but this is a nice graphical representation of the overdose deaths that are occurring in the United States and that trend over time. These maps of the United States are produced by Dartmouth Atlas. In the top left, you have 1999. The blue, which you're not going to be able to see from here, the dark blue indicates 4 overdose deaths per 100,000. And then the dark red is more than 20 overdose deaths per 100,000. So you see 1990s through to 2004, 2005, through 2010, and then 2011 to the current state. And we've had a dramatic increase in overdose deaths over that time frame. Because of that, and the numbers for 2017 that were recently published actually increased this. We're now in 2017, we had 72,000 folks in the US who died from overdose deaths. It's the leading cause of death for Americans under 50 years old, and that's per year more people than died, or more than all of the US servicemen that died in Vietnam. More deaths than at the height of the HIV epidemic, et cetera. If we look at the geographic variation of opioid use in the US, it kind of mirrors what that map looked like. You can see that Idaho is in the light purple, number of painkiller prescriptions per 100 people, and it's 82 to 95. And then this is the Idaho task force produced this. This shows, so Kootenai County here, we're prescribing average MME per prescription of greater than 58 to 70 morphine medical equivalents, and we'll talk about that later, what that means if you're not familiar with those terms. And then you can see the bubbles show the percent of high prescribers. It looks like kind of southern parts of the state, there's a lot more high prescribers from the physician standpoint than we have here. Okay, so why has this become such an issue? And this, we're going to spend just a moment on this one because opioids are extremely addictive. This was published by the CDC in 2017, and it looked back 2006 to 2015 at the prescriptions that were given and then the likelihood of continued use. So what this shows that if your days of supply of the first opioid prescription was, say, 15 days, and if you move up, you can see that the 1 year probability of continued use after a 15-day initial prescription actually puts you in at about 25 to 30%. So if you give a 2-week prescription of opioids, you've got a 25 to 30% chance at 1 year you will be continuing to take opioids. And then the 3-year likelihood comes in at about 15%, but it's pretty close linear relationship there. The last slide, which is going to talk a little bit in our pathway, as well as continued work that the network is going to do. But what this looks at is where did the prescription opioid come from for people who didn't used to take opioids who are now taking opioids within that year. So last year they didn't take them, this year they do. And the gray bars there show that most are given by a friend or relative for free. So it's that leftover prescription from an acute injury, a surgery, what have you, that ends up in the pool, causing folks to become chronically addicted. And then the red bars, which are the next most common, are prescribed by more than one physician, so indicating that need for you to be checking the data bank to make sure patients aren't getting prescriptions from multiple providers. In Idaho, there's, with the national work going on, Idaho really ramped up quickly and pretty aggressively about what they were doing. There is a multidisciplinary interagency task force that has been established, and we have a couple of folks from Kootenai Care Network that have participated in that. From the prescriber side, most of you know that there's now a prescriber report that you're receiving on a quarterly basis that tells you how you're doing. That information today is not being used at any licensing boards, although everybody nationally expects that that will become part of a licensing process in the future. And then they have a large public education effort. The education effort on the Idaho standpoint is educated at providers, the public, and then they have set this interesting target of reducing the rate of opioid prescriptions so that more than 85% of written prescriptions in Idaho should be under 80 morphine equivalents, which is only 10 5 milligram Percocet tablets as an example. They've initiated drug take-back programs, and they're advertising those to patients. And then on Kootenai Health side, we have also somewhat mirrored this work as well as what's happening on the national standpoint. We have set up the Kootenai Health pain committees as well as the Kootenai Care Network pain work group. There's an inpatient team working on acute pain, and that's around reducing the number of newly addicted patients, making sure that initial prescription is as small as possible. We have the chronic pain patients in primary care. which you're going to hear a fair amount tonight with the pathway. And then there's additional work being done for chronic pain in the pain management program and work in the future about de-escalation and detox. Okay, so with that, I'm going to hand it over to Dr. Magnuson to walk us through the next bit.
So we'll go over a few more slides here before we start the discussions. So the chronic pain work group put together the chronic pain pathway. And before this seems really loud, is that okay? Sure. Before we start talking about chronic pain and how to manage it, you need to have a good framework on a definition of what chronic pain is. And so an appropriate and widely accepted definition is that chronic pain is something that lasts for longer than 3 months or lasts longer than what is considered the normal expected recovery or healing time. When you're assessing chronic pain, this is just kind of a small list, but obviously if you're treating somebody for chronic pain, you need to have an established patient-physician relationship. That includes getting an adequate history, doing an appropriate examination, and getting supporting documents that you need to look at. You need to have a clear documentation of a pain management contract if you're going to treat them for chronic pain, and there's plenty of good examples of this. If you're treating them for their chronic pain, they should have their pain assessed at every visit. And how we do that, I think there is in the policy, there are some references for how to do that, but just simple pain assessment tool, or something called the PEG is a new one, and I won't go into that, a relatively recent one. I won't go into that a whole lot of detail because we don't have as much time, but it kind of addresses a bit more of the multi-dimensional aspect of pain, not only their pain rating, but also how it impacts their function and how it impacts their quality of life. Prescription monitoring report should be done at every visit. Is everybody familiar with the prescription monitoring report through Idaho and through Washington? I think it's fairly common and standard now. It's something simple and easy to look up. It literally takes seconds to less than a minute, and it's an important tool. I will have to say, in my personal experience from having done pain management here for 19 years, and we've used the Idaho prescription monitoring program for many years before it became a bit more mandatory. And it was very frequent that you would find evidence of doctor shopping around when we started looking at that. Over the last couple of years, I don't see that so much anymore. I think it has made a positive impact. Physicians are using it, they're checking it, and I think that's been positive. I think we need a national one, but that's my own little diatribe, and we won't talk about that tonight. There should be a mental health screening, at least initially with the patient, and periodically through the visits. Something like the PHQ-9, or frequently, I think a lot of clinics will do a PHQ-2 or PHQ-4, which kind of is a quick look at depression and anxiety, and then decide whether you need to give the whole assessment or not. And then urine drug screening is a big thing. If you're going to prescribe these medications chronically, and most primary physicians, primary care providers are going to do that, you need to do compliance monitoring, and this is a mainstay of that. Generally, a good rule of thumb is to get an initial urine drug screen prior to writing the prescription, and then periodic urine drug screens after that. The frequency of how often you need to do that can depend, but most people who practice chronic pain will base that frequency on a risk assessment of how likely they are to misuse their medications. And that's not on this slide, but I think there, again, in that policy, there are some other references for that. We use a quick and easy tool called an opioid risk tool. It doesn't take patients long to figure out, but it's validated, and it gives us an idea of how likely they are to maybe misuse their medications. And then the other crucial component is patient education. It may start with the RAC cards that offices will be given, and it just begins to introduce to the patient where we are as a community and as physicians in approaching chronic pain. There are some further educational materials that are in development, nothing that is out right now. I think one of the key things is setting realistic expectations from the beginning, setting what your goals are, and the realistic expectations actually work for both the physicians and the patient. I think historically, both physicians and the patients have expected opioids to carry a workload of chronic pain management, and they really never were designed to be able to do that. Studies looking at chronic efficacy of these medications, at best, you're going to, I always tell patients this, at best, we're going to get maybe 30% improvement with chronic opioids. I think in the past, the paradigm and the feeling from patients and us as physicians have been, if I'm going to treat them with opioids, they really shouldn't have any pain. So the patient comes back and they say, I'm still having a lot of pain. So the next step is to increase the opioids and increase the opioids. And pretty soon you're finding yourself in a little bit of trouble. Kind of the example I used the other day when we were talking too is, if you're treating someone for hypertension and you begin them on a medication therapy for that and you reassess and see them back 3 months later, if you're still struggling with it, you're going to reassess your treatment and you're going to try something different and new. It's no different with pain medications. You begin that therapy and you reassess them. If it becomes obvious within a period of 2 or 3 months that you're not achieving the goals that you wanted to achieve at the beginning, you need to step back and reassess your plan. And then the other part of this is provider education, which is what we're all doing here tonight to expand your knowledge breadth and just essentially kind of network with other providers and see what people are doing and try to practice best standards within the community. All right, so we'll begin our active learning at this point. So this first case, it's a person who has persistent low back pain for a period of 10 weeks, moving furniture into his new home. It's kind of with everybody from California moving up here, you probably have seen these patients before already. He's tried and failed a number of different things, a TENS unit that he had previously, Tylenol, ibuprofen, got some over-the-counter pain products, creams, hasn't worked. He's done modalities like heating pads and ice packs, just haven't worked. Because the pain was going on for 10 weeks, he ended up getting an MRI. And like many MRIs, kind of non-specific findings. Sure, there's some degenerative changes, maybe a small disc bulge, but nothing that clearly points to the ongoing pain. So based on this information, what's the best option for the next step on this patient? And this is the audience participation time. You get to use the clickers, and you can pick A, B, C, or D. There we go. All right, so there's the distribution, 2% for A, the majority of people, answer B, C, and then a smattering of people for D. So, probably overall the best answer would be B. Consider some non-opioid therapy, which could include physical therapy for this patient. It can include a number of other things, acupuncture, interventional pain management, whatever. But the idea is to consider non-opioid therapy and make sure you're maximizing that before we start moving on to opioid therapy. Possibly, depending on the patient, may be a candidate for short-term opioid therapy, but it needs to be carefully assessed. Again, this is only at 10 weeks, not fitting the definition yet of chronic pain. And so probably not a good candidate for long-term opioid therapy. All right, so kind of a multimodal non-opioid approach first is the idea behind this pain pathway. Opioids, if you look at CDC guidelines, are rarely indicated for chronic pain. I think it's still controversial that the literature does not support long-term use of chronic opioids for pain management. And That's partly because the studies aren't there, and we're still working through this. But it is clear when you look at the literature that there are dose-related adverse consequences from opioids. So they really should be low on the list. You want to stabilize whatever contributing conditions are present. You want to try to use that multidisciplinary approach, whether that's physical therapy, occupational therapy, massage therapy, getting a pharmacist involved. Again, interventional pain management, surgical therapy, whatever that might be helpful. Lifestyle modifications, cognitive behavioral therapy, things like that. If you do reach a point where you have given adequate trials of everything and they're still having significant pain and you think that they are a candidate for some opioid therapy, it's best to start off with short-acting medications first. Use those. And again, like many medications, you want to start low and go slow. And provide the lowest amount possible and have regular follow-ups and adjust therapy as necessary. The goal is really to try to keep the morphine equivalents less than 50 milligrams a day. If you need to go above that, there should be good reason and documentation of why you want to do that. And again, the goal is to keep it below 90 milligrams. And again, we're talking about chronic non-malignant pain. And those aren't arbitrary values. If you look at the studies, there's kind of an inflection point around 50 milligrams per day where you start getting that dose-related adverse effects from opioids. And when you start getting above 90 or 100 milligrams a day, that curve goes up even faster. And when I say adverse effects, I'm talking about even inadvertent overdoses and death. It starts rapidly increasing when you get to doses over 50 milligrams a day. And if you are co-prescribing benzodiazepines in those patients, the curve is even steeper. Refills by appointment only until they're established and on a stable dose and they have a good track record. But if I'm prescribing opioids for patients, the very maximum that I'll go before I see them again is 3 months. But generally, it's always a month until we're very stable. And then again, it goes back to if the treatment plan is not working, you're not getting goals, and goals with opioid therapy is not only pain control, but just as importantly, if not more importantly, functional improvement. If you're not achieving those goals, then it becomes time to have the discussion of, okay, we're going to start withdrawing this therapy and looking at other methods. Okay. So the second case, patient that you have is prescribed 10 milligrams every 6 hours as needed for pain. So they get 28 for 4 weeks. So essentially they're using 4 a day. 4 a day for a week, I should say. I'm sorry. Just to see how many people are familiar with the morphine equivalents per day. At 10 milligrams every 6 hours or 40 milligrams of Percocet a day, what is the total morphine equivalent of that medication? A, 30, B, 40, C, 60, or D, 90. And again, use your little clickers. So a little bit more variation on the answers between all those, but 60 milligrams is the one that most people decided, and that is correct. Oh, I thought we had a slide that. And that would be correct. So this shows, and this is on the CDC website, a conversion calculator for morphine equivalents. Conversion calculators are all over the internet. If you Google them, I think the CDC app has a calculator on it as well. The Idaho PMP, Idaho Board of Pharmacy site does, and so does Washington. But these values, and I'm not sure how well you can see them, are pretty standard. There's a little bit of variation depending on who you look at, but most conversion calculators are using these factors now. So for the person that we talked about before, they're getting 40 milligrams of oxycodone per day. Oxycodone's conversion factor is about 1.5 times that of morphine. So it's 60 milligrams of morphine equivalents a day. So in a prescription that's not that uncommon in our community, they're already over the 50 milligrams of morphine equivalent a day at that dose. All right, so that brings us to our last session.
So this is the part where we're really hoping to get some group discussion, and that's one of the reasons why we put everyone at tables. I think that this is a perfect forum for a lot of us with, I think as we're practicing, kind of trying to get a sense of where everybody else is at. So as we go through these cases, we're really hoping that you can discuss these with each other and kind of figure out how you're managing these issues. And for those of you specifically in primary care, these are going to be some cases that are very common, probably a daily occurrence for you. So our first case is the existing patient in your clinic that you've had for over 10 years. They are on oxycodone 20 milligrams, or OxyContin 20 milligrams TID, and Percocet 5 milligrams Q6 hours PRN. So at this point, we want to give you 5 minutes at your tables to discuss how you would plan on discussing tapering with this patient. And so we'll give you about 5 minutes, and then we'd like to hear some responses, and we can also comment on that. Okay, so is anyone brave enough to talk about how you would handle this patient, as I'm sure you all have?
Sure, Andrew Rokeys, Valley Medical Care in Hayden. The two options we talked, the main thing we talked about was you would decrease it like, a little bit amount of time, maybe 10-15% per month, and you'd slowly wean them off. And then the two ways we discussed doing that was maybe you would go down on the OxyContin, maybe, I'm not sure what it comes in. If it comes in 15, you can go 20 to 15 or 20 to 10. The other option is that we also talked about was cutting down the quantity. So if you got like 90 pills one month, maybe go down to maybe 80 pills the next month, and then just kind of cut it 10% each time. So that's one option.
Why are you telling them you need to do it?
Oh. Well, yeah, you're right. So, we were thinking about that. What was the morphine mil equivalent? So the 20 milligrams of OxyContin, that was 30, right? No, it was 20, so it would be equivalent of 90 morphine mil equivalents. And plus the Percocets was 5 milligrams every 6 hours, so that's about 7, so 4 is about 30, roughly 30 milligrams. So you're at about 120 morphine mil equivalents, and if your goal is to get them down to less than 90, you need to kind of work on that there. So you're a little bit above goal.
Tim Burns, and I'm from Ironwood Family Practice, Family Medicine. The problem is this person has been on this for this period of time, so they have no interest in coming off of it, and you're saying that you're trying to help them, but so what would be good is an actor or someone up here who's coming for the responses for everything that you say, which is what we get in daily practice. And you've been taking care of him for 30 years, and he's been on this for 10, and you take care of everyone else in his family, by the way, too. And so now I have no interest in coming off of this. This is finally where I can function throughout the day. Doctor, why are you saying that I have to come off of this? I'm not going to play this part, by the way.
I was going to say, we talked about role playing, so next session you can be part of that.
But I'm just saying that I came here because I need realistic ability to get these people off of this type of thing, and it's not uncommon. And I want to do that. I also want to be able to help them and have been trapped in some of these situations.
Yeah, so I think the plan, that's a great segue, is that Dr. Green was going to talk through how she would address this and describe it in the office, and perhaps some clinical pearls of how she holds the line. That would be helpful.
I think I'm in a little bit of a unique position in that I've only been here for a year and a half or so. So it's very easy to inherit patients and say, this is the safe way to do this. However, I've had many conversations where patients said, why would my doctor do this for me if this isn't safe? And I think I get that conversation fairly frequently because people are very trusting in their the medical professionals in their lives. And so I've had to have that conversation of, you probably, a lot of you have your kind of canned speech about this, but where I've come to is, with in the medical professional, we're constantly working on trying to use the best data that we have at that time to take care of you. And so with a lot of these patients, I have to say, I have no doubt that your physician had your best interest in mind and was trying to treat a symptom. But what we're finding now is there's a huge harm, and we're not seeing the benefit that we were hoping. And so that is kind of how I initiate that conversation. Obviously, there's going to be a subset of patients that don't care, and that's probably going to be a large percentage, but we still have, I've had a lot of patients who have successfully weaned off narcotics over the last year and a half, and I think that those are the cases that make all this work at trying to do this with patients worth it.
The information at the beginning of the talk around, the medical profession, we were really taught for years and years that was the standard of care. And now it's recognized with all of these deaths that you're hearing about on a daily basis. The numbers keep rising, that in fact, these opioids that we thought were good for you are actually not. And, we need to have the same care for everyone.
Well, I'm just going to address that a little bit too, because I know that you get a lot of that. And it's part of just kind of reassessing people all the time and deciding what the best treatment is for them. When they're at high doses, obviously that risk-benefit ratio starts getting a little bit out of kilter. And one of the things too that you need to remember is that when someone has been on doses like this for a long time, even though it's well-meaning and they say, I'm doing pretty good, I think, there's a couple things that happen is that there are consequences of medications that are, or of opioid medications this long at that high of dose. And one of them is something called opioid-induced hyperalgesia. So if you're on higher doses, you start getting to even 60, 70 milligrams of morphine equivalent a day and over, you actually can have a central nervous system that becomes sensitized. And it's paradoxical. So the opioids are kind of serving to propagate the pain issue. And so I always bring that up with my patients, because I have many patients that we can wean down off of opioids, and they've been on these drugs for a long time. And not everyone, but it's not infrequent at all, that people get to lower doses or possibly even off the medication, and they realize that they feel better. And they don't necessarily, they're anxious at the beginning, but they don't necessarily appreciate that until they're down on the doses. We've had a patient recently that Denise, our nurse practitioner, has been working with, who is very anxious about it. And every time she came in, she expressed that anxiety, but she also expressed, I'm feeling better. I kind of forgot. This has come on so slowly and gradually. I kind of forgot. I thought I was handling this just fine, but I've been depressed, I've been down, my family's noticed it, but I haven't appreciated it, and I feel better coming down off these medications. So sometimes you have to convince them that, yes, I know it's not going to be easy, but it's potentially unsafe for you, and because of that opioid-induced hyperalgesia, there is a good chance that you could feel better on the lower dose of medication. And if it's been 10 years at these higher doses, it's time to think about a change.
So that is actually in this packet as well. But if you're going down by the 10%, in here it says 10% per week. You'll see some data that says 10% per month. But and I think reassuring your patients that they will likely have very little withdrawal symptoms if you are going down at that slow of a rate. I think, like you were talking about, it's a little bit tricky with dosages, because 10% is, for some of these people, trying to find a dose is a little tricky with that. But yeah, that 10%, there's, like I said, it says 10% per week in here, but I think if you look at up to date, it says about 10% per month. So.
Well, I would just add an anecdotal story to this, that I had like you, I'm about a year and a half into practice here, so I inherited a lot of patients, and I had somebody come in with doses of about 300 or 400 milligram equivalent morphine a day, successfully come down to about 60 now in a matter of 6 months. But I guess my question, kind of related to what we were talking about here, we're getting people on pain contracts and checking Board of Pharmacy and things like this. So how are you addressing violations of these contracts? Because, they're violating their contract, but then it's not necessarily safe to just cut them off completely.
Real quick. And I would say this is challenging for us, is just in the ER too, because we'll see people don't tell us when they're in withdrawal. They'll come in with these symptoms and pain or diarrhea, and then oftentimes you start looking at the PMP and you can kind of see that they've either been on a taper and they're running out early, they ran out early, and that's challenging for me too because I don't know. These are a lot of these people have other comorbidities, and just letting them go through withdrawal is not really the safest thing. And so trying to find a medium ground, I think one thing we were talking about was trying to stay away from some of the benzodiazepines and some of the other controlled substances, but at the same time still converse with them about the issue. I found, frankly, that in those circumstances, if you bring it up and talk with them, they're pretty receptive to a plan or being open to it. Oftentimes they don't want to tell you because they're very embarrassed or whatnot. So now that we have this access to the information and the PMP, it really helps. And so oftentimes they won't tell you that until you go kind of like deduce what the problem is, and then you bring it up with them in a respectful way. And I find that really helps. That's just my perspective. I'm not in the clinic though, but that's what I would see, because we see that a lot. It's you don't put it together until you actually really look at the PMP. It takes some time. So.
Yeah, and there's a lot of reasons for them violating their contract, and that kind of depends. Your response is going to depend on what that is. It's different if you do a urine drug screen and it shows methamphetamine. My response is going to be a little bit different than if they're calling the clinic, out 4 days early because even though we had tapered down to, 5 oxycodone a day, they've been using 6 on some days, and now they're out a few days early. Then that lends itself to a discussion on the taper and adhering to the plan. But I someone who's positive for an illicit substance like that, then they get to go through withdrawals, or they probably won't, but I won't. You offer them treatment for their drug abuse, and you don't prescribe again.
Yeah, and I think that as this where we're at with this whole thing is really kind of up to us, and I think that's up to us to determine is how we're going to manage these patients. And we've came to a lot of kind of new thoughts in this group, and this whole talking about this is big. I think just because everybody deals with this, so any ideas are helpful.
Hi, Brad Brzezinski, Family Medicine. What do you do with people who are positive for THC because they're taking CBD oil or whatever the heck else is out there?
I don't think CBD oil should cause a positive urine drug screen, does it?
I've seen it, yeah.
Okay. Either way, I mean, our policy within our clinic is that if you have any substances which are not prescribed and which are considered an illegal substance, I mean, I think CBD oil obviously is different, but patients are most patients I have a lot of patients who are getting marijuana products over the border now. So I have been very explicit that if that is found on their urine drug screens, they will no longer receive it, because the same thing with benzos, the same thing with any of these other products that your risk goes up significantly with any
While I have the mic, what do you do about Washington? Because Idaho PMP doesn't cross border Washington. It does with Oregon, but what do you do about that?
It's been difficult. I actually have been trying to get it for the last 3 months.
Yeah, it's not easy.
Yes, it's become a lot harder. So I don't have a good answer to that. We're working on it right now. Okay, so I think this is probably actually a little bit easier patient for all of us, because this is the person who has moved out of state, and we're seeing a lot of people coming from one specific state who are coming on fairly large doses of controlled substances. So this is the patient who's moved into town after retiring. They are on morphine 30 milligrams TID, hydrocodone 5, 325 Q4 hours is needed, and lorazepam 2 milligrams TID PRN. So again, the question is, how would you de-escalate this therapy? Which would be your first step? And if you decided to continue therapy, how would you do that? So we'll give you another 5 minutes for that.
Why are you looking at me? Just because I open my mouth all the time? Hi, I'm Peter. I'm with Heritage Health. We used the handy-dandy cheat sheet, and we elected to taper the benzos first. Following the guideline on the side, though, I guess I'm a little confused about the 25 to 50% reduction in the first dose. Literally, like on the slow taper chart, it says reduce the calculated dose by 25 to 50%. Is that kind of the starting point?
So that is when you're switching from a short acting to a long acting. You're just accounting for that
Yeah,
dose.
so you switch it from the short to the long, but then you calculate the total dose and then reduce it by 25 to 50% right off the bat.
So just because of because of the metabolic variance, just as we talk about with opioids, that there's also going to be some of that as well.
I don't know much about the opiates, but I do psychiatry, so I know a ton about the lorazepam. And I would really question how somebody was. Oh, Peter Gorley with psychiatry at Prairie Family Medicine. I don't know, I don't know if the person's really actually using it 3 times a day, because lorazepam is a fairly sedating benzo in my experience. They're probably using that at night, like 2 milligrams or probably 4 milligrams. So I'd really find out how much they're using. And then it's on paper looks good to switch from a short acting to a long acting, but diazepam is a lot different benzo. It's more sedating. It has a higher index for relaxing muscles, which is good. But there's a lot of people that can't function real well on diazepam. And then there's genetic mutations in a lot of folks that I check where they just don't metabolize that well. And diazepam breaks down into temazepam, which is a sleep aid. So some people get hung up at the CYP2C19 where they can't get rid of that. And so diazepam's a complex drug. It can have a half-life of anywhere from 20 hours to 200 hours. So I think that's fine. But if somebody was really using lorazepam in the day, I would probably switch it over to clorazepate, which breaks down into Valium, and oxazepam, because I find that it's not as sedating. Either that or Librium seems to work well, and it's not as sedating as Valium. I just don't use Valium very much because it's just people just don't function well on it.
Who else? So we're going to hit the benzos first, then what? Who you are, where you practice?
This is Becky Birch, internal medicine. So kind of like the last case, looking at this, once we can get the lorazepam, and I agree, we need to see how much they're using the lorazepam to see it, can we still keep it on as needed? But the combo of the benzos and the morphine is what concerns me. And then going with the long acting, I think it's always a good strategy. I personally have no reason to have somebody on a long acting more than twice a day, because these are typically 12-hour medications. So then I'd go with starting with the long acting to say, let's start with tapering that 30 milligrams 3 times a day. When is your pain the worst? What time of day? Is it morning? Is it nighttime? Does it wake you up from sleep? And then whatever is their best time of day, saying that's the time of day that we're going to either start reducing that morphine dose and eventually getting it to twice daily dosing, and then alternating that with the short acting and trying to really maximize the person's function to where they're then more willing to say, okay, we need to look at other modalities. Let's get you into physical therapy. Let's get you into pain management. What other things can we do that are non-narcotics to maximize your pain benefit or comfort? So.
Thanks. I think for the sake of time, maybe if our panel can just give closing thoughts or recommendations.
I don't know if I had opening thoughts. Well, a lot of this, I think it's good to have a framework, and it's good to have guidelines. A lot of this comes down to a bit of common sense and the so-called, art of medicine, how you approach people and get them to buy into your plan and become an active participant in it. One of the things that we talked about is, bouncing things off of your, fellow physicians in your practice or calling people. I think that's important. If you have someone who's a problem, maybe trying to get some other input and feeling like you're not an island in here, to enlist some other people to give some input and help with these difficult patients, I think is important. So I think we can help each other out that way.
I don't know if I've
I always hear that opiate withdrawal never kills anyone, but man, I've seen some pretty bad stuff happen to people while they're in withdrawal with renal failure and these kinds of things. So, I think I find that what I've seen over the last 11 years I've been here, I've been involved in our pain committee for 10 years now, 8 years, is that there's been a dramatic change, and not only just from new people coming into the community and spreading their ideas, but just overall, I think people are moving towards more modalities that are non-narcotic, and so I've noticed a big change, and I would hope that we'd move forward, and I think. What we talked about earlier too is that, like all things, I think that the pendulum will swing, and what I wouldn't want is that there's people suffering, and then we start cutting people off and not treating pain. But I think we just need to treat pain a little differently, and I've seen that change, and that's good. So hopefully this is helpful for people to talk about it here tonight.
Well, I can just, I'll finish up. So I actually, it's interesting. If you have time, you should read this book, Dreamland. I think it's just interesting reading about the trends of how this all came about. I was in training in medical school when I remember my attendings giving me the 1% statistic. And these were my attendings who are also telling me to treat based off evidence-based. And so I think as physicians constantly trying to obviously treat our patients the best we can, but also trying to utilize what we do know at that time and trying to keep our patients safe is a huge responsibility of all of us. And I think that using this as a learning, that we have seen what's happened. And I think, as you were mentioning, trying to not necessarily go back to the other side of the pendulum where everyone's suffering, but trying to utilize our best evidence at that time. So.
Okay, all right, thank you. Let's give our panel a round of applause. Yay. Please fill out your CME sheets and turn those in on the way out. And then we did record tonight's session. It will be available on the Kootenai Care Network website for others to view, as well as the various documents.